Hello, everyone. My name is Kerri Cornejo, and I'm the Policy Coordinator for the Federal Office of Rural Health Policy, which is part of the Health Resources and Services Administration, or HRSA for short. So as part of the Rural Telementoring Training Center launch week, today I'm going to share some information with you on telementoring from a federal and rural perspective. So the goal for my session today is to explain this perspective through our vision more broadly on the use of telecommunications for health and healthcare, how telementoring aligns with this vision and helps to achieve these goals, and lastly, the importance of the Rural Telementoring Training Center in putting this vision into action. To get to today's learning objectives, first I'm going to provide you with an overview of my agency, HRSA. Then I'm going to discuss our telehealth and telementoring activities at HRSA. And then lastly, I'm going to wrap it up with the talk about telementoring through the rural and federal lenses. HRSA is an agency that's part of the Department of Health and Human Services. It supports more than 90 programs that provide healthcare to people who are geographically isolated and economically or medically challenged. HRSA primarily does this through funding grants and cooperative agreements to more than 3,000 awardees, which include community and faith-based organizations, colleges and universities, hospitals, state and local and tribal governments, and private entities. And every year, HRSA programs serve tens of millions of people, including people living with HIV/AIDS, pregnant women, mothers and their families, and those otherwise unable to access quality health care. The Federal Office of Rural Health Policy, where I sit, is part of HRSA, and it's also the part of HRSA that administers the Rural Telementoring Training Center. We have 4 mission-focused divisions in our office. I'm part of the Policy Research Division. This is also where the Rural Telementoring Training Center sits. Primarily, we focus in this division on policy and regulatory analysis, research, and we fund programs with a strong focus on health policy issues. And when I say health policy issues, I mean especially those issues tied to payment policy or healthcare delivery systems. And this slide here is just to illustrate the relationship between the different agencies. So you can see rural health is within HRSA, which is an operating division of HHS. So for the last 30 years, HRSA has been a leader in the field of telehealth. HRSA's first telehealth program was actually funded back in 1988, and that was funded through the Federal Office of Rural Health Policy. Until very recently, the Office for the Advancement of Telehealth at HRSA was part of the Federal Office of Rural Health Policy, but it's since moved outside of rural health to go under the larger HRSA umbrella to reflect the fact that telehealth is really expanding beyond rural communities, especially with COVID-19. It's called OAT for short. So OAT has 2 roles, a programmatic and a policy role. So through the programmatic role, OAT provides funding for direct services, research, and technical assistance in the field of telehealth. And on the policy side, OAT comments on telehealth policies with a focus on rural and underserved communities. They also serve across HHS to leverage telehealth to improve access to care, enhance outcomes, and support clinicians and patients. And they also promote the use of telehealth technologies for healthcare delivery, education, and health information services. And now that OAT is its own office within HRSA, it can focus on rural and urban issues. It will serve as that focal point for telehealth across HHS and enhance coordination with other key partners. And while telehealth remains a very important topic within rural health, it's playing an ever-increasing role in both rural and urban communities alike. And so looking at, you can see this through our funding, and looking at fiscal year 2020, HRSA awarded more than $1 billion for telehealth activities, and they had approximately 3,876 awards in fiscal year 2020, and this was an increase of over 100% from fiscal year 2019. And you can see here how telehealth has grown rapidly as a component of HRSA programs over the last few years. And this is both in rural specific programs and in other parts of the agency as well. You could see health workforce in the health center programs, those are the federally qualified health centers, maternal and child health, the health services field, and in the field of HIV and AIDS. And this kind of gets to the next point with the telehealth focus areas. They've been broad across HRSA, but some of the big ways you see it applied at HRSA is through primary care, behavioral and mental health care services, substance use disorders, including opioid use disorder, among other areas. So what is telehealth? It's important that we have a mutual understanding of how we define telehealth, particularly so you understand our telecommunications focus and how telementoring fits in, which I'll get to shortly. But HRSA defines telehealth as the use of electronic information and telecommunications technologies to support and promote long-distance healthcare, patient and professional health-related education, public health, and health administration. And telehealth technologies used include laptops and desktops, smartphones, tablets, apps, smart devices, Bluetooth devices, video conferencing platforms. Audio only is considered to be telehealth, typically through telephones. There's store and forward of images and remote patient monitoring. At HRSA, we see telehealth playing an important role in benefiting the health and healthcare of rural and underserved communities through increased access to services, improved workforce development, and better care delivery. There are benefits of telehealth to the provider, the patient, and the payer. And so for the providers, we see it as improving workforce development. It also reduces professional isolation in remote areas. It improves care delivery. It allows providers to serve more patients, and it's also been lowering no-show rates as well. For patients, it increases their access to care. They can get care closer to home, which also reduces their travel time and reduces their wait time to receive services. It might result in the patient missing less work or school, and less wait times for emergency services as well is also one of the potential benefits of telehealth. And then for the payer, telehealth reduces costs for transport. It allows for more timely care with the potential for better outcomes and lower costs. As I mentioned before, COVID-19 also illustrated some of the additional benefits of telehealth. And saying all this, we do recognize that while there are many benefits to telehealth, it's not for every patient or for every medical situation. So I talked a lot about telehealth, but what's telementoring? HRSA doesn't have a set definition for telementoring like it does for telehealth, but the concept was described in a recent report from the HHS Office of the Assistant Secretary for Planning and Evaluation on technology-enabled collaborative learning and capacity building models. They described telementoring using the ECHO-ACTS definition as being a distance health education model that connects specialists with multiple other healthcare professionals through simultaneous interactive video conferencing for the purpose of facilitating case-based learning, disseminating best practices, and evaluating outcomes. Telementoring is distinct from telehealth, though many models exist alongside telehealth-related mechanisms, including direct care telehealth, e-consults, and other mechanisms, according to that report, which went on to suggest that telementoring can be implemented as part of a suite of strategies for telehealth delivery. So in other words, telementoring can coexist with telehealth strategies and may be well suited for it, both leveraging telecommunications with the goal of enhancing patient care. So the report I had discussed in the previous slide also cataloged the use of telementoring models across HHS programs. And for the purposes of the report, they refer to them as ECHO and ECHO-like models, or EELM for short. The report found widespread use of technology-enabled collaborative learning and capacity building models across HHS, with the majority being administered here at HRSA. There was also substantial diversity and variation across these HHS programs. And so these programs vary by content area, target mentees, the number, frequency, and duration of sessions, whether an intervention ends at a fixed number of sessions or is open-ended, whether an intervention is geographically targeted, and how it is funded. However, many of the grants are relatively small in size, or they were not entirely focused on EELM or telementoring, which made it hard to compare funding across agencies. So in fact, a major finding of the report was the need to strengthen the evidence base on patient and provider outcomes. Evidence to support telementoring was modest in these programs, though it was promising. And so the reasons for this might include the lack of standardization of measurement for program implementation and outcomes. And another key finding was the lack of funding applied towards evaluation, with most of the funding being for implementation. So ultimately, it was the opinion of HHS in this report that expanding the evidence base could help to encourage the expansion of telementoring models. The ability to evaluate and expand telementoring models is important given all its potential benefits, including sharing knowledge more efficiently as a more formal structure to rely on expertise that leverages technology, connecting remote primary care providers to specialty teams, and enhancing provider capacity through collaborative learning are both other benefits. And these are especially important in rural areas where access to specialists is often limited, and primary care practitioners may need to address conditions or problems that require additional expertise. It can also help to address important gaps in care for underserved populations. So as I just said, of course, being in the Federal Office of Rural Health Policy, we're really interested in how it can help rural communities in particular. And I'll actually cover that in the next slide. And other potential benefits of telementoring include improved provider retention, enhanced quality of care, better population health, and reduced wait times. So as I noted, I'm especially interested in the role that telementoring can play in addressing some of the core issues in rural health. Rural populations often have difficulty accessing specialty care, perhaps due to workforce issues or travel times. So telementoring can help close that gap by bringing some of that care closer to home. Rural patients are also generally older and sicker, indicating a need for greater access for care. And rural providers often see lower patient volumes, which means they might see some conditions only infrequently. So then telementoring can help support provider capacity by opening doors to collaborative learning that might not have existed before. There's also the growing need to respond to new and serious emerging public health issues. Of course, we have COVID-19 is the perfect example of this right now. It started in larger cities, but then it eventually spread out across the country and into rural areas. And then before COVID-19 and still ongoing, we've seen the opioid crisis that may require providers to have specialized knowledge in many cases in treating opioid use disorder and some of the comorbidities that might go along with it. And the ability to have access to telementoring can help patients and providers in rural areas with addressing these public health challenges. So the key thing I would say, what makes telementoring an especially promising model for rural communities is the potential to empower providers in rural locations to pursue additional resources to meet the challenging and evolving needs of their patients. So I emphasized in rural locations to drive home the point that this can help provide a better way to serve patients where they're at in the community. So I think I've explained why telementoring is an important tool for rural communities. So why was it important then that HRSA fund the Rural Telementoring Training Center? So I think it gets back to the key pieces I mentioned earlier on the need to both expand the reach of telementoring while establishing a solid foundation on which to evaluate and sustain telementoring models. So to get to that goal, funding the Rural Telementoring Training Center can help us to establish a clear understanding of what telementoring is. It can also help us to grow the capacity to assess and evaluate telementoring, both individually and as a concept. And also it could help us to build the structure to support implementation and ongoing operation of telementoring programs. So my last slide here wraps up the presentation by highlighting the goals of the Rural Telementoring Training Center from our federal rural perspective. The purpose of the program is to train academic medical centers and centers of excellence in the creation of technology-enabled telementoring learning programs. The Rural Telementoring Training Center exists to develop and share freely accessible tools and resources that are adaptable to culturally and regionally diverse populations, and to provide training nationwide to facilitate the dissemination of best practice specialty care to primary care providers and care teams in rural and underserved areas. It also serves to identify and expand current and new telementoring learning programs. As part of that, it will create a standardized telementoring learning program data set and evaluation toolkit. And it also serves to define program measures that reflect both key outcomes and important processes. And these should illustrate the impact of the program on telementoring and rural healthcare access. And the last thing I would want to say is, of course, we're excited to be able to fund this program and to be able to work alongside the RTTC team. So I want to thank you for listening to my session today. I'm happy to take any questions that you may have today, or if you would like to reach out to me in the future, you can find my email address here on the slide. It's kcornejo@hrsa.gov. And HRSA is also available. You can follow us on a number of social media platforms. You can find out more information about our agency at www.hrsa.gov. And we also encourage you to sign up for our HRSA e-news newsletter. So thank you very much. It was my pleasure to be able to join you today.